warm welcome to our Zoom webinar organized by GMOA and Society for Health Research and Innovation. Before going to today's session, I have a delighted announcement to be made. From today, each participant of this webinar will be receiving an e-certificate for the participation. And please stay with us until the end of this session, and we will be releasing the link in the chat box. Now, we are moving to today's topic, diagnosis of Parkinsonism and principles of management. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts. Now, it's my utmost pleasure to introduce Dr. Darshana Sirisena, consultant neurologist currently attached to the Colombo North Teaching Hospital, Ragama. He is also the President-elect Association of Sri Lankan Neurologists. Thank you, sir, for joining us today, and the floor is yours.
Good morning, and at the outset, I should thank all the organizers of this CPD session for inviting me to give this lecture. I hope you can see the screen. So today's topic is diagnosis of Parkinsonism and principles of management. So at the outset, I'm going to show you a video, and just for you to make your interest. So just see whether you can see whether this patient has Parkinson's or not, right? Just keep it on mind. Okay, good. So what I want to know is whether you just go through the video. If you want, I'll play it again and see whether you can you have to decide whether this patient has Parkinsonism or not. That is number one. If you think this patient has Parkinsonism, on what grounds you make the diagnosis. Secondly, if not, if you think this patient doesn't have Parkinsonism, on what grounds you don't think so, right? Just once more. I'm showing some physical signs here. Okay, thanks. So today's topic, I'm going to concentrate on three areas. I will first give an introduction. Secondly, the first part of my talk will be on diagnosis of Parkinsonism. Thirdly, I will mainly concentrate on the management of principles, because I'm just touching on the management principle, because if not, the management is an entire 30 to 45 minutes topic. So this is the second commonest degenerative neurological disorder we encounter. You know what, when it comes to the etiologies of conditions, there are infections, there are inflammatory conditions, there are tumors. So there, as well as there is something called neurodegenerative. Degenerative simply means with the age, as we all know, there are certain amount of cells in our brain losses its function. So in certain patients, this loss is accelerated and they have symptoms which is due to the loss of brain cells. So that is what we call as neurodegenerative conditions. When it comes to the commonest neurodegenerative condition is Alzheimer's disease. This is the second commonest. So if you take the prevalence of Parkinsonism is around 1%. So you know, in this country, we have around 20 to 22 million population. So we usually should see about 220,000 patients. So, but that is not the issue. The WFN means the World Federation of Neurology. Last year in their World Brain Day campaign gave the prevalence to the Parkinson's, and they predicted in 5 years time, that is in 2025, right? In 5 years time, this number is going to be double. So we are usually, the current number is going to get double. So this condition mainly affects elderly. But that is elderly in the sense it's after the 50 years of age, not keeping with the current trends of classification of young and old, right? But it's what we call, it is more common in the 50 years of more. But having said it, we at the present, we see a lot of patients with Parkinsonism coming around 35 to 50 as well. So that's what I want to admit here. It's not an uncommon in young patients as well. So this condition was first described 204 years ago by Dr. James Parkinson. Actually, this condition is named currently under his name after the French neurologist Charcot named this condition and gave the full credit to him and named it the Parkinson's. So according to this essay he wrote in the British Journal, So even today, if you see in your right hand side, if you can see the one of the pages he described this condition, he says involuntary tremulousness with lessened muscle power in parts not in action. So that means a tremor, as you all know, there is tremor associated, which is in rest. And with a propensity to bend the trunk forward. You know, if you have seen a Parkinson's patient, they have very stoop posture. So that is what he describes. And from walking to running pace and sense and intellect being uninjured. That means the patient's the memory and other things not improved, which is not true. But even this 204 years ago, according to his description, majority of his features are still valid. So this is the pathophysiology of, there is a deposition of Lewy bodies in area called basal ganglia. You know what it means. Basal ganglia is the part which is responsible for producing dopamine. Dopamine is very much responsible for our many functions in our system, but mostly when it comes to the neurology, the muscle movements and to keep the muscle movements and the coordination. So what happens here, for some reason which we don't know still, the Lewy bodies get deposited in the area of this basal ganglia, and this the cells are destructed little prematurely. For an example, if a 60-year-old patient has not Parkinson, this is, if you can see the picture here, their basal ganglia area is very much markedly, there are sufficient cells, but this pigmentation is much preserved. When you do a Parkinson's patient, you can see there is not much cells for some reason, which we don't know still. The Lewy body deposition causes destruction of the basal ganglia cell. As a result, there is not sufficient amount of basal ganglia cell which can produce the dopamine. So the important thing is severity is directly related to the nigrostriatal lesser. Nigrostriatal in the other word means a part of the basal ganglia, which is about 10 times when compared to normal. That's what I told. If you take a 60-year-old patient, if a patient's Parkinson's patient cell loss is about 10 times more than a normal person who doesn't have Parkinson's. So when does the cell the symptoms come? It's about, they have found about 30% of cells should be lost at a time the first motor symptom to be diagnosed. But the important thing is here, next 5 years, when you have started you got this the condition, in next 5 years, then another 50% of the cells will be lost and the disease gets progressed. So now they have again found there is this cell loss actually begins 5 to 10 years before the first motor symptom appears. So that's what we call a pre-symptomatic stage. We are the lot of research has been done to find any tool. I will come to in the next couple of slides to find an test which, if we can find a person before developing the symptoms. Unfortunately, we haven't succeeded in that area. So this is why I told. So person gets, see here the arrow indicates that they are age of 50 years, this is 0. Yeah, the patient is first diagnosed of Parkinson's at this age. What they say, actually the disease starts very well before, about at minimum of 10 years, they actually say about 20 years because at the age of 30. But during this period, that is called pre-symptomatic stage, you couldn't diagnose because there is no any tool. But here is the main important thing, where the patient appears with symptoms, and thereafter, with the time, patients, if the patient lives for about 20 years, their disease progresses, which is called from the mild to mild disease to they progress to moderate to severe disease. So the key is here, unfortunately, if you don't know, this is one of the important objective of this talk, to diagnose some patients with Parkinson's very early stage. Why I am saying so, if you diagnose the patients at the very early stage, you can manage them very well. Their quality of life can be improved as a normal person. So unfortunately, what is happening today, we wait until the patients get moderate to severe disease, which should not happen. If that is why I want to stress the importance of this talk, how to diagnose this one. So the important message I want to give you, this managed diagnosis of Parkinson's entirely clinical. You don't need to have any investigation. If you are a doctor, if you are a medical officer, if you are a registrar, anyone who is in Kartankot should be able to diagnose as well as National Hospital, because there is no need of any investigation. This is a entirely clinical, where you should know what are the diagnostic features. So for that, there are various guidelines exist. As I mentioned before, the most important is to diagnose early mild stages. So what is Parkinsonism? It's a condition. It's a neurological syndrome, as you all know, where manifested by a combination of clinical signs. So what are they? These signs are independent. That means sign A should not be there to have B, right? So those are complete independent. They are not overlapping with each other. And importantly, all these deals with the motor function of the things, that is the movements of the patient. So all these are, again, it's a neurological syndrome which is manifested by any combination of independent, non-overlapping cardinal motor features. What are they? The first thing called tremor at rest. So if you know, tremor could be defined into two, classified into two. One thing is a tremor at rest, the other one is tremor at action. So this is predominantly tremor at rest. So second feature is what we call as rigidity. Rigidity doesn't mean spasticity, it's a totally different thing. So rigidity is, as you know, when you move around the joint passively, you can feel some resistance, that is called rigidity. This is extrapyramidal, or what we call as a cogwheel rigidity. Third feature is echinacea or bradykinesia. I would like to use the most correct term would be bradykinesia. So kinesia means movements. Brady is slow. So the term would be slowness of movements. So sometimes very advanced disease, they have echinacea as well. The fourth feature, they say, postural instability. How do you know postural instability? They have frequent falls. So that is difficulty in walking. So these are the four clinical features a Parkinsonism consists of. What are they? Tremor at rest, rigidity, echinacea or bradykinesia, and postural instability. So it's a nice mnemonic you can remember. TRAP. T stands for tremor, R for rigidity, A for echinacea, and P for postural instability. So I'm going to show all the clinical signs now. This is the first clinical sign, the tremor at rest. I hope you can see. So see the patient's right hand. So patient has a involuntary tremulous, or what we call as oscillatory movement around the at the wrist. As you saw very clearly, it was the patient was when resting his hand on the lap. But now when patient's posture is initiated, the patient holds his hands against gravity. It is not there. That's the predominantly of a postural hand, so rest tremor. So this is completely eliminated when the patient holds his hands against gravity. So, but in some patients, especially in advanced, they have a postural component as well. So next feature is what we call as bradykinesia. Look at the patient's right hand, right? He has a tremor, as you saw. So see, when the patient tries to open and close his fist, what happens? Very slow. Just checking with you, if you don't have Parkinson's, just check it. It's not very slow. These called finger taps, right? Finger taps is with the thumb and index finger, try to check. On the left hand, it's again slow. Can you see? This is not the normal movements, right? And this is alternating pronation and supination. So there are three maneuvers we can do in upper limb to check the bradykinesia. Simply all these movements are what we call as repetitive alternative movements. There are three things, if you can go through the video again. One thing is it called opening and closing, right? That's what he does, opening and closing. As you go, as the movement goes off, the patient's velocity and amplitude reduces. And the other maneuver is called the finger tapping. So with the index and the thumb, he tries to tap as fast as possible. In Parkinson's, which is very slow. And the third maneuver is called as pronation and supination. That is also slow. They start a little bit fast, but as the time goes, it becomes slow. This is bradykinesia. This is how you check the rigidity. As you know, the rigidity cannot be explained by a video, but this is how you perform. You just passively move around the joint and you will feel the cogwheel type of rigidity. So that is something you have to feel. This is how you perform, right? So if you suspect a patient of, this is how you do it. The next is what we call as the postural instability. Look at this patient's gait. So see what walks. The patient doesn't move, swing his arms when you walk, and see what happens when the patient trying to turn. So he's like blocked, or what we call as frozen or freezed. So this is called freezing of gait, or what we call as hesitancy. Hesitancy is when the patient want to turn, they can't turn as a normal person. Look at this video again. So this is when the arm swinging is lost, and when he wants to turn, this is not like a block is turning, right? Someone is right, like a robot is turning, not a normal person turns. This is what we call as freezing of gait or turn hesitancy, right? So this is the next one. So this is a full picture of the stoop posture. I saw the patient has very stoop posture. That's what I told, and sees what happens to when the patient wants to turn. So very difficult to turn, right? Like it's called freezing of gait, or the other word in specifically, this is turn hesitancy. So when the patient wants to turn, it's very difficult disease. So this is what the postural instability means, right? Fortunately, this comes with a very early stage of idiopathic Parkinson's. Good. Okay, we'll go to the, when you want to confirm in your clinic setting whether the patient has postural instability, this is what we do. So for the registrars, this is very important. This comes as OSCEs as times, right? So so this is what we call as pull test. Pull test is how do you check the patient's balance or the risk of falling. This pull test, how you do, ask the patient to stand up and keep the patient's feet little apart, and you behind the examiner behind and try to pull from the shoulders, explain what for the patient and check whether, and ask the patient if the patient want to improve, or the patient what the patient task is not to fall, and ask them if he want, he can keep couple of steps backwards to prevent from falling. So see what I am doing. So I explained, and I told him, as you know, it's a Parkinson's tremor, you can see. Give a small pull. So now he says he again give a little bit more power, right? So the patient actually here, the pull test is negative because patient improves or the patient recovers within couple of steps keeping behind. If the patient can improve with minimum of 2 steps, sorry, maximum of 2 steps, the patient can wait without falling. The pull test is called checking the retropulsion. So again, I'll show you because the importance of this comes in OSCEs at times. It's called retropulsion or pull test. Patient recovers within couple of steps. He doesn't fall. Good, we'll move. Right. So now the golden question is pre-symptomatic diagnosis and biomarkers. As I told, before the first symptom appears, the brain changes had started. That is what they have found. The most important challenge is at the PD research at the moment to identify an individual who are at risk of PD. If such, they can start some management. They can make some modification to slow down the illness. Is it? Unfortunately, we haven't found. As you know, if I give an example, diabetic patients, there are certain things called pre-diabetic stage with blood sugars and other tests you can see. But here they have tried so many biomarkers. They have started clinical biomarkers, olfactory testing, genetic testing, CSF biomarkers. But unfortunately, so far, we haven't found any test. But there's some promising evidence. Impaired olfaction is one of the earliest signs of Parkinson's disease. They are trying to have a lot of tests on that. Nothing is validated so far. So the message here, there is no tool or investigation to diagnose at pre-symptomatic stage at the moment. So now we'll come to the causes of Parkinsonism. Now you know how to diagnose Parkinsonism. The next important thing, causes of Parkinsonism. It is very simple. There are 4 causes only. First and most important thing, or the commonest thing I would say, the primary, or what we call as idiopathic Parkinson's disease, IPD. Second thing is secondary. This is something to do with the dopamine release in this condition, as you know, the pathophysiology. So secondary is drug. The common is drug induced. Our psychiatrist colleagues are the commonest responsible, the commonest culprits, because they use a lot of dopamine blocking drugs. Because of that, a lot of some psychiatric patients in long run with antipsychotics develop Parkinsonism. So this is a secondary cause. That means there is a cause that you can identify. Third variety is the third type of the Parkinsonism, what we call as atypical Parkinson's disease, or what we call as Parkinson's plus. There are 4 conditions especially coming under. There are a lot. I'll discuss in a couple of slides. Right. The final thing is what we call as genetic or heredodegenerative. As you know, there is genetic young onset Parkinson, there is genetic related, and the most commonest condition we should not miss in a heredodegenerative condition is the Wilson's disease, where the patient comes with Parkinsonism features. So again, if you find the causes of Parkinsonism, it comes under these 4 broad categories: the primary or the idiopathic Parkinson's disease, the secondary, commonest is the drug induced, or what we call antipsychotic induced, atypical Parkinson disease or the Parkinson's plus, and finally the genetic or the hereditary. So now I will come to the how to diagnose idiopathic Parkinson's disease, which is the commonest out of that 4. So there is a guideline called, there are a couple of guidelines. Actually, I'm going to discuss two. The United Kingdom Parkinson's Disease Society Brain Bank criteria. I'll mention how this criteria initiated. In the brain, what we call in the United Kingdom, this called University of College London, they have a brain bank. What they say is, they after the patient dies, they collect the brains and dissect. You know how to diagnose Parkinson's. The gold standard is you have to found Lewy bodies in the thing. So what they say, they took, for an example, they took 100 patients with Parkinson's, suspected Parkinson's, and they did a post-mortem on the brain, and as a gold standard, they found to have they try to find whether there is the Lewy bodies. If the Lewy bodies are there, you know that Parkinson's disease. And they retrospectively analyze their symptoms, what they came up, and develop a criteria what is more specific and sensitive in diagnosing Parkinson's disease. Their step one is, these patients should have bradykinesia and akinesia. You know what bradykinesia and akinesia now means. I have showed you. So if that is there should be at least one of the following. That is called rigidity, rest tremor, and impaired postural stability, right? So if these, with bradykinesia, at least one of these features are there, you can diagnose this patient as idiopathic Parkinson's disease. That is what I told. These symptoms are independent and non-overlapping. So if a patient has bradykinesia, slowness of movements, from which you did, and in at least one of the following features, the rigidity, the rest tremor, and impaired postural stability. When it comes to the impaired postural stability, you have to make sure you know the postural stability could be due to, if the patient has visual problems, he couldn't have. So you have to exclude the other causes like visual, sensory neuropathies, any problem with vestibular system, or cerebellar. If all are normal, then you account this patient as postural instability due to Parkinsonism. So that is very clear. So now you diagnose as Parkinson's. The next step is you have some exclusion criteria, as I said. What are they? If the patient has usually basically all these signs are meaning there is a secondary cause. So if there is a stepwise progression, you know, if a patient has an injury, they can develop Parkinson's. So you don't call it as idiopathic Parkinson's. If the patient has encephalitis, actually even now with the COVID, the epidemic, some have found in UK, they have later has developed Parkinsonism features, right? So there are a lot of research going on. So if there are a secondary cause, you don't call as idiopathic Parkinson's. This exclusion criteria is all. I am not going by single one. So if you can see this list, so all these are features for secondary causes. If you can find this, if any of these are present, you are not calling them as idiopathic, but mind you, all these has patient as Parkinsonism. So then comes the supportive criteria for idiopathic Parkinson's. What are the supportive criteria? Unilateral onset. One of the most important thing I have to stress here, all these idiopathic Parkinson's patients, their symptoms are initiated unilaterally. So in one side, right? The rest tremor is one of the thing. Progressive, as I told, the nigrostriatal cell loss is with time. So because of that, there shouldn't be any stepwise progression. That means be steadily progressive. Even the patients develop into stage 3 or stage 4, there should be a persistent asymmetry. That means one side should be, the symptoms should be worse than the other. Especially the patient where the patient symptoms initiate, that side is worse. That's what called persistent asymmetry, worse on the onset side. And other important features, these patients are very much responsive to levodopa, the commonest drug we use. Actually, there is a, what I'm not going to discuss there, it's called levodopa challenge test. Even what if you have suspicious of idiopathic Parkinson's disease, there is called a levodopa challenge test. That means you challenge a patient with a levodopa challenge, their symptoms markedly improve. So there is a very good levodopa response. Other side of when there is a levodopa response, they develop severe levodopa-induced dyskinesia, like coliform movements, which I'll show you in a video later. And the other important thing, this is very slowly progressive condition. Because of that, there should be at least more than 5 years levodopa responsiveness, because at a very later stage, maybe stage 3 or 4, the patient levodopa response gradually declines. And the other important, they should have a disease course of more than 10 years. So if these features are there, they are very suggestive of idiopathic Parkinson's. So first step, we diagnose the Parkinson's with bradykinesia and any of the other features I told you. Then you exclude secondary causes. Third step is give the supportive evidence. So there is another the diagnostic criteria, that is UK PDS criteria, which I mentioned before. They mentioned this is very simple. If you don't want to recognize the previous one, this is very simple. They say 6 features. What are they? The tremor at rest, bradykinesia, rigidity, posture, the 4 which I mentioned already. And in addition, they freezing of gait and flex postures, which I already showed you in a video where the patient is walking. All this I showed you. The fifth and sixth, you called it as the motor blocks. These patients are suddenly, they walk, suddenly they block. That's called freezing. So the motor blocks. If these features are there, definite Parkinsonism, if out of these features, the patient has Parkinsonism, all the features, if one should be tremor or bradykinesia. Then probable is there, as you can remember, as you can see, either out of the first four, they are either one of these following. So possible when the features 5 or 6. Then comes the staging of the disease. This is called the Hoehn and H and Y. It's in short term. I'm not going to discuss in detail about this. What I want to show you, when you start to diagnose a Parkinson's patients, you can put them onto a staging system. That is called, this is very important when it comes to the rehabilitation. So starting from stage 1 to 5. So simply the stage 1 is a very mild disease, that is called symptoms is only present on one side. That is only unilateral, right? Then it comes, when it comes, as you can see, stage 3, which is called mild mid stage. The symptoms appear on both sides as well as the axis, and but still the patient's balance is mostly not compromised here. Stage 5 is very severe disease where the patient is completely wheelchair bound. So these are the stages. These called Hoehn and H and Y staging. You can go Google and see if you want to have more details, which is most importantly for the when the patient, how the patient progresses the disease to stage. Then I told you there is a other thing called atypical Parkinsonian syndrome. There are 4 conditions we discuss under this one. The progressive supranuclear palsy is one. You know, PSP, or previously called as Steele-Richardson-Alzheimer's disease. The second thing is multiple system atrophy. The corticobasal syndrome, or CBS, some call as CBD, also corticobasal degeneration, but the common better term would be CBS. The fourth atypical Parkinsonian syndrome is diffuse Lewy body disease. So what these features, how these difference from the idiopathic Parkinson? These patients have very rapid progression, early onset dementia and hallucinations. If a patient comes with Parkinsonism, which I told you the features, and they have very early onset dementia or hallucination, you have to always think about secondary Parkinsonism, not secondary, sorry, atypical Parkinsonian syndrome, especially if they come with these. That is what we call as a diffuse Lewy body disease. If they have hallucinations and dementia, you might be dealing with a patient with DLBD. Early onset of loss of balance, or your patient comes with frequent falls. There are 2 conditions you have to think about Parkinsonism coming with early onset loss of balance and falls, either PSP or multiple system atrophy, because multiple, and the patient comes with features of cerebellar and the autonomic features, you have to always think of multiple system atrophy. And if the patient has upper motor neuron side, that means upgoing planters and other things, we have to think about the corticobasal syndrome and sometimes multiple system atrophy as well. So if the patient has a gaze palsy, specifically vertical gaze palsy, you have to always think of PSP in a patient, right? So these are features are more in favor of atypical Parkinson's. If the patient, mind you, all these patient has, if the idiopathic Parkinson's patient also has these features, but the important thing is these features doesn't appear in the early stage, they come at the later stage. In the atypical Parkinsonian syndrome, all these progression is rapid, all these recurrent falls, they have cerebellar, autonomic, all these symptoms are very early stage of the disease. So now I have already discussed the first part of my talk, that is the how to diagnose. And I also told you what are the commonest causes as well. That is in 4 things I told you, that is idiopathic, Parkinsonian plus, secondary Parkinsonism, and the hereditary degenerative. So I've given a brief outline on them. So now we'll come to the management of Parkinson's disease. So when it comes to therapeutic, you all know the patient has to be started on treatment. So when it comes to therapeutic principles, there are 4 principles that we adhere. The first thing is always give priority to any therapies. It could be a drug, it could be surgery, it could be device that have been established as protective. What does it mean by protective? That should be that if that drug or surgery should able to slow down the disease progression. If you can remember, I already told you, unfortunately at this moment, at this date, there are no such treatment that slows the progression of the disease. There are a lot of studies going on, study that completed, but there is no statistically significant data to give a therapy. Maybe in the future we might be having. Second thing is encourage patients to remain active and mobile. So in our setup, not like the Western and other settings, you know, when a patient has when we say the patient with Parkinson's may be very early stage, what happens in these patients, They go and Google and see what they say is the Muhammad Ali's or Cassius Clay's picture, where the patient's very later stage after 20 years what happened to him, and all the friends, all the relatives gather and say, don't go, don't walk, be at home and on. This is not the thing. You see, no, always if you diagnose Parkinson's patient, especially early mild to moderate disease, they should be encouraged, active and mobile as much as possible. That is very, very important. So that actually helps to patients. Mobility is much important. And the other thing is keep the patient functioning independent as long as possible. For an example, a patient with 54 years, right? So the 54 years, if you diagnose, sometimes what the patient does, they try to retire on the next day, which shouldn't happen. So patient should be functioning independently as much as possible. Patient should not be functioning independently without support only at the very latter stage of what we call as very advanced disease only. So keep in mind that you always stress the importance of functioning independent as long as possible. Final thing, the most important thing is there is no the patient's treatment strategy should be individualized. For an example, you might be an executive bank executive coming to you at the 50 years of age, and you diagnose very difficulty in writing or very slowness, sometimes very mild intermittent tremor, you diagnose as Parkinson's. And this patient's management should be different from patient who is in from Kabitigo 50-year-old farmer, Akrepatu, so wherever this patient needs and the patient's affordability, which I discussed in the video, is different. So you have to assess the patient's needs and treat individual. That means two patients can't manage in the same manner. So their patients' needs must be different, patients' affordability must be different. So all these have to consider when you are treating. So these are the 4 therapeutic principles. If there is any treatment, you have to treat that patient with any agents available, which could be neuroprotective. Unfortunately, at this moment, there is nothing. Patient should be remain active and mobile. Thirdly, patient should be functioning independently as long as possible. Finally, the patient's management should be individualized from the one to the other. And when it comes to management of PD, there are three major areas you can manage. First thing is called non-pharmacological management, which is called the rehabilitation aspect, which I will show you video. The non-pharmacological method, very, very important in today's context. Second thing is the pharmacological agents. This could be again divided into neuroprotective medications or agents or the symptomatic. Unfortunately, there is no neuroprotective agent so far, which is trial proven, or which is called statistically proven. There are certain drugs they have proposed, but nothing is proven yet. So all medications we have at the moment are symptomatic. Third option is surgical option. There are surgical options which we call functional neurosurgery as well as open neurosurgeries. Functional neurosurgery, that is the most widely used at the moment, what's called deep brain stimulation surgery. It's not available in this country at the moment, right? So these are the 3 things: what non-pharmacological, pharmacological, and surgical. So as you know, when it comes to the pharmacological management, so what is the pathophysiology behind? If you can go back, somehow the dopamine releasing the cells has been depleted. Therefore, enough dopamine is not produced in the body. So that is the pathophysiology behind it. So somehow, with whatever the treatment you do, you need to improve or you need to provide sufficient amount of levodopa to the body. So what is the easiest? You give levodopa as outside. That is called levodopa replaces dopamine. So that is the most important medication we use at the moment, called L-dopa or levodopa. That is the most important and the most effective medication. Other one, the levodopa is broken down in the body by what we call as catechol O methyl transferase, COMT. So if you can give an inhibitor for that, COMT inhibitor, so you can preserve the levodopa either with the drug that you are giving or whatever the existing levodopa in the body you can. So that's another class of drug, what we call COMT inhibitors. Then there are certain drugs what we call as dopamine agonists. That's called, it mimics dopamine, it acts like dopamine. So what we call as dopamine agonist, broadly called DA. So the other one is there are certain things called MAO-B inhibitors. MAO-B is some selegiline and resigiline. Preserves existing dopamine. That's why there are a lot of research is going on whether these MAO inhibitors can be used as a neuroprotective agent. Unfortunately, studies has not given enough or sufficient data on that aspect. So if the other class of drugs is MAO-B inhibitors, so that preserves whatever the existing, so thereby they can, theoretically they should be able to slow down the disease progression. So these are the therapeutic principles or pharmacotherapy principles. You can replace levodopa, or you can give an agent which reduces breakdown of the already available levodopa, or can you give a dopamine agonist which acts like dopamine, or increase by whatever the existing dopamine could be preserved by what we call MAO-B inhibitors. So these are the therapeutic choices available. I'm not going to detail. This table shows all the drugs which are available. The dopamine precursors, which is called the levodopa. You know, this is when you give a levodopa, it's been broken down in by dopa decarboxylase. You have to give a dopa decarboxylase inhibitor with levodopa. That's why it comes as benzerazide or carbidopa. So there are a lot of formulation, intermediate release, continuous release, dissolvable mouth. So I'm not going to discuss detail on this one. These are the drugs available which are given to comes under the categories which I showed in the previous ones. So the important is what medications start. As you showed, there are about 10 groups or 10 classes of medications start. So what should guide the patients you to make the decision whether which one is started. There are things, many factors, not even single factor. There are many factors which will be helping determine the choice of medication. So one of the important things, age and overall health of the patient. So simply what I am saying, if you are coming across a patient with 45 years old and another patient with the 65-year-old, your management, the medication you are going to start is different. I'll say why, right? So age and overall, if the patient is very active patient, even at 65, you might consider some other medication than a patient who is diagnosed as Parkinson's, which is maybe not mobile as much as maybe because of various factors. So age and overall health of the patient is very important. So the second thing is, most of these medications, especially the most effective medication, levodopa, has motor side effects. So what we call as in long-term use, they develop motor complications. You have to be very careful about development of motor complication. Third thing is the other comorbidities associated with Parkinson's patient. And because you know the majority of these patients are elderly, because you have to consider other comorbidities patient might have, like dementia, the orthostatic hypertension, sleep disturbance, etc. Finally, in this country, the other most important factor you have to consider is the cost of the medication. For example, if you need to start a patient with Selagelin initials, it's a tablet is around 300 in this country. But fortunately, the levodopa preparations and some of the dopamine agonists are available in our system, in our the public health system, so you can give it. But in certain patients, if you want even to start some medications which are expensive, you might not be able to find it. That's what I told. Always individualize the therapy. So cost of the medication is also a factor we need to start. So this is the very dreadful complication I told as a result of levodopa. This is a patient with levodopa-induced dyskinesia, severe chorea. Generalized, most of the time this patient is on this movement because of the, so sometimes the patient prefer not to have any medications to prevent this complication. Right, okay. So this is what we call dyskinesia, generalized choreiform movements due to levodopa. Right. So these are symptomatic. I'll come to the symptomatic treatment of in early disease. So this is very important. Early disease is very mild disease, maybe unilateral involvement. So patients, and in these patients, sometimes patients do not necessarily need treatment. You can discuss the condition with the patient. For an example, if a banker comes to you, he says, I am little slow, or the patient might say, I have a very mild tremor, which is intermittent. When I get stressed up or something like that, I get the, so you can discuss with the patient and you can delay starting initiating of treatment because their work or quality of life is not affected. So patients do not necessarily need treatment at the initial stages, but you have to convey that message to the patient. We'll wait for another 6 months or 1 year. We'll review in about 3 to 6 months and we'll discuss whether you need to start, because as I mentioned, all the medications which I mentioned are symptomatic only. Because sometimes if you have to remind the fact early treatment does a better job in maintaining quality of life than the improving the patient's disease modification. So you have to give that option. If the patient has a tremor, it's very troubling, but patient can manage his vector, you have to can say that there are certain medications which you can improve your quality of life. So give that option to the patient. So many factors, as you mentioned, in help in designing an initiation of symptomatic treatment in the early disease. What are they? They should be improve the quality of life. The patient is slowness, patient can't put a signature on the check or the can write, then they should start levodopa of this patient. Their symptoms may improve. So thereby the quality of life might improve. And need to ability of the continuing medication. That's what I told initially. The patient should not stop work. The patient should continue on his working. Therefore, the drugs might help. And disability could be reduced more obviously. Finally, the patient's attitude towards medication is also very important. So when it comes to early symptomatic treatment, as I mentioned, levodopa is the most effective symptomatic treatment. So, but the issue what I mentioned is when it on long-term use, when you use it for many years, maybe 2 to 3 years time, they develop very dreadful motor complications, which I showed you before, what we call as dyskinesia. So mind you, the patient comes with the 45-year-old. So if you want to start levodopa, you might have to use this drug for another 15 to 20 years in these patients. So you have to be little careful. Maybe the patient 5 years time coming, very severe dyskinesia. Because of that, you might delay initiating these patients, younger patients, delay initiating the dopamine. But if a patient is 65 years old, 75 years old, or sorry, 70 years old, if the patients, maybe you think the patient might go with the disease in about 5 to 6 years, you have to improve the quality of life to the maximum. So in those patients, you straight away might start levodopa. So the other group of drugs, the second commonest or the second most effective drug is the dopamine agonist. There are two groups in Sri Lanka at the moment. One thing is propinerol, the other one is pramipexole. The issue with these two drugs are they are less effective than levodopa, but the issue with these drugs are they have a lot of side effects. Mainly they have affect the cognitive effects. They have sometimes hallucinations. That because of that, it is not good for all the patients, but is very good as an initiation therapy, mild to moderate disease in young patients. So what are the initial treatment considered? I'm putting a cartoon here. If there are three scenarios, if a patient comes with young age, for an example, may just maybe 45 to 50. So minimize long-term dyskinesia risk. So what you need to start a dopamine agonist. That's what I told previously. You can start a small dose of pramipexole or propinerol and step up as the patient needs. Second is an older patient, maybe 65 to 70 years old patient. So the patients, you have to minimize cognitive effect because you know the dopamine agonists are more prone to cause the cognitive effects. Therefore, you without starting dopamine agonists, you straight away in these patients start levodopa. Finally, patients with very mild symptoms, as you know, they suggest at the moment no need of a dopaminergic medication. That means neither levodopa preparation, no dopamine agonist. In these conditions, you can start amantadine or inhibitors. Sometimes they might help you to prolong the disease they can stop the disease progression to a certain extent, though there are not enough evidence. So these patients, always these patients should be followed up. So these are three clinical scenarios. So now I'm coming to the latter stage again. Now, do you think this, just go through the video I showed you before and see whether this patient has Parkinson's. As you clearly see, the patient has bradykinesia. So the issue I put that video, this patient doesn't have the characteristic tremor, but still this patient has bradykinesia, this patient has, and it is asymmetrical as. So this patient has idiopathic Parkinson's disease. So if you thought patient has Parkinson's, you're good. If not, at the end of the talk, if you think that now the patient, I am confident that patient has Parkinson's, I think I have fulfilled my objective. Yeah, you can very clearly say there is slowness of the movement, especially on the right, asymmetrical. So this is a patient with mild to moderate disease or early to mild disease of Parkinson's, idiopathic Parkinson's. Now I'm going to show you a video here, which was very recently put in the NEJM. As I mentioned you, the pharmacological treatment. So you know, when the pharmacological treatment is started, with the disease progress, when the patient goes about 10 to 15 years, the drugs doesn't work for various things, which I'm not going to discuss, I told you. So these patients, the rehabilitation or what we call physical therapy is very much important. See, this is a study they done in States, which showed the pedaling, continuous pedaling, how the patient's Parkinson's has improved.
England Journal of Medicine.
So you can see this patient has severe Parkinsonism, shuffling, freezing of gait.
Him to the parking lot, and off he went,
So see how this
pedaling
patient
perfectly, even executing a U-turn.
This gives Parkinson's patients throughout the world reason to be optimistic.
But how can you go from this 1 minute to this the next? Dr. Jay Albert's been studying the effects of pedaling on Parkinson's after his own amazing discovery. Albert, an avid cyclist, went on a 50-mile tandem bike ride with a friend who had Parkinson's. In this video shot before the ride, his friend's hand shook wildly, but afterwards, steady. So Albert started a trial at the Cleveland Clinic. Parkinson's patients pushed to pedal hard.
10 minutes, a little harder, I'll get your heart rate up.
The result? An improvement in motor functions that lasted for weeks.
I haven't had any meds yet today, and I was shaking pretty good. But this exercise, it's amazing.
Researchers still don't know why it works. One theory, pedaling releases chemicals that improves motor function. The same theory behind this. Parkinson's patients able to dance.
This is a transporting exercise. When I come here, I don't have Parkinson's.
For patients, intriguing mysteries that could put a new spin on treating their disease. Sharon Alfonsi, ABC News, New York.
So what actually they showed in these studies with physical therapy, so how the patients, especially with the advanced Parkinson's, can improve with physical therapy. So this is what I put this video is, in most of our units, in neurology units, most of in our hospitals, they have a physios, occupational therapist, and all the therapists which we can have a successful rehabilitation program, which could be do wonders. The pathophysiology behind what they explain is, in our system, in our brain, there are a lot of tracks which have not been used so far. There are thousands and thousands of tracks in the brain which has been dormant for a long time. By changing for certain things like cycling, group dancing, group therapies, you can activate the certain tracks which were not functioning before by releasing certain chemicals. A lot of research has been going on this one. Very promising at the moment, as you have shown in this video. So probably in a country like ours, where the resources are limited, like for deep brain stimulation, other things, this might be a very important. Okay. So finally, I'm coming to the end of my talks. What are the take-home messages I want to give you? Parkinson is very common. The issue is you don't diagnose early. And importantly, I want to mention this idiopathic Parkinson disease is the commonest. Unfortunately, it is very underdiagnosed, especially at the early and mild disease. There is no point in diagnosing a patient after 5 years of illness. Any person could diagnose a very severe tremor. The importance of this talk I told you the very important clinical features which you can diagnose Parkinson's. As you now know, there is no need of any investigation. This is entirely clinical. So at the moment, there is no medication which had been proven neuroprotective. All the medications which are available are symptomatic. So out of the medications, the levodopa remains the main pharmacological agent, but dopamine agonists are important, have an important role in the management, especially at an early stage of the disease and a patient with younger age. The most important important message I want to give is should be individualized. The management should be individualized and patient-centered, considering various factors which I mentioned. So if you have any questions, you can, I think, if the chat, we can have a thing. Otherwise, you can drop me an email, right? So I can respond. Thank you very much for your patience hearing. Once again, I should thank all the organizers of this GMO and the Shri organization for giving me this opportunity. It's a wonderful thing, and I wish all the very best for their future endeavors as well, right? Thank you very much.
Thank you very much, sir, for that really informative presentation. And it's time for a few queries, sir. Please write your question in the chat box. So we have a question from a participant. How can we manage motor complications in Parkinsonism?
Yeah, it's a very good question. I didn't touch on that because another entire topic. When it comes to motor complications, there are a lot of complications. For example, there are 3 main complications. One thing is called wearing off effect. Wearing off effect means simply if a patient's the effect of the drugs wears off with the the next dose. I'll give an example. If a patient takes a drug in the 7 in the morning, then next dose is at, we'll say at 1 p.m. So by around 11 o'clock, the patient's symptoms, the tremor reappears, the bradykinesia gets worse, which we call as a wearing off. So what you need to do, you have to increase the amount of drugs. If you are giving a quarter tablet of levodopa, you can increase to half. The other option is you can increase the frequency. Instead of every 6 hours, you can give every 4 hours. Second thing is, sometimes this is what we call as wearing off or predictable loss. Some patients have unpredictable loss. Sometimes you can't say when the patient gets the off periods. It's very difficult. So you have to ask the patient to maintain a diary, and a lot of things can be done. You can add a dopamine agonist, you can add a continuous release preparation, a lot of things. And the other complication is the dyskinesia motor complication, which I told. When it comes to dyskinesia is also very important. There are three types of dyskinesia. One thing is what we call as end of dyskinesia. That means, again, if the patient take the Syndopa, whatever the amount of at the morning or 7 in the morning, the next tablet is due at, we'll say 12 o'clock. The patients develop severe dyskinesia by around 11 o'clock, within 1 hour to next hour. This is called end of dose dyskinesia. So this should be managed. You have to again increase the dose or give some other things which increases the amount of levodopa in the body. The good thing is you can add entacapone, which is called a corticotropin or methyl transfer inhibitor. The other dreadful thing is called peak dose dyskinesia. Peak dose is when you take the drug, within about half an hour to 45 minutes, patients develop severe dyskinesia, and it lasts for about 45 minutes, 1 hour. So this is managed completely different to the end of dose dyskinesia. You have to reduce the dose at that time. So that's why very important to identify which motor complication you are dealing with, right? So that's how it goes. You have to see what motor complication the patient has, and then adjust the medications. You might have to change the medication. So there are a lot of options, right? So that's how you can manage each. And if you have specifically one this motor complication, you have answered. These are a broader thing, right? Okay.
Thank you very much, sir. That was a clear-cut explanation. So please bear with us. We have a few more queries from the participants. The next question is, how long it will take to develop Parkinson's dementia?
Yes, usually that is very important. As I told you, if you diagnose very early at the very motor within first year, now they have realized it takes a minimum of 8 to 10 years to develop some sort of a dementia. It's called dementia is I hope she or he is referring to Parkinson's disease dementia. You know, most of these patients are old, elderly patients, so they have some degree of dementia as well. So what is the important thing is to diagnose whether this patient has Parkinson's disease dementia or the normal the dementia due to the normal aging, or sometimes they might have Alzheimer's dementia as well. So the important thing is, if you want a clear-cut idea, it is not early. So if you come, the Parkinson's disease dementia is usually late, maybe after minimum of 10 years, I would say. That is a later stage, right? Providing that the patient was diagnosed at the early stage.
Thank you very much, sir. One more query. What is the place for benzhexol in treating Parkinson's disease?
Yeah, good question. So benzhexol, that is we commonly use as Artane. In my experience, that is very much useful for patients to alleviate or to good response for tremor. That doesn't help much for bradykinesia or rigidity. If a patient comes, his main symptom is the tremor, even you don't need to start levodopa on these patients. Artane might help. So Artane is mainly a symptomatic treatment, I would say, for tremor. So there is another form of, in another classification, you can tremor dominant Parkinsonism. In such patients, benzhexol is very useful. You have to start very slow doses and increase gradually with looking for the response of the patient. So mainly to alleviate tremor, I would say.
Thank you, sir. The last question is, what's the maximum daily dose of levodopa?
There is nothing like that. There is not maximum doses. Actually, I have been using half a tablet or one tablet per patient every 2 hours. That means sometimes about 8 to 10 tablets. There is nothing. The patient can tolerate. You can go for the maximum, provided that it doesn't cause us dreadful side effects, as I mentioned, the dyskinesia shown to you, right? The important issue is, as the disease increases or the severity gets worse, maybe the stage 3 or 4 disease, the impact or the benefit of levodopa reduces, right? Especially they don't absorb as well in the early stage, like the early stage. So their benefit is much less. Rather than they having causing a benefit to the patient, they cause a lot of side effects. Then sometimes it might not be useful. In other countries, what they say use is what we call as apomine infusion, which we call as the theory behind this, we call continuous dopamine stimulation of the body, right? So various the oral or what the way we take it has a lot of effects on the continuous dopamine stimulation. So the question for your answer is, there is no upper limit. As far as patient can tolerate, you can continue up to whatever the dose, provided that there is no dreadful side effects.
Thank you, sir. A few more queries we have got from the participants. Next question is, when should we refer the patient to neurologist with the features of Parkinsonism?
My urge, or what I urge, as much as earliest as possible. The important thing is, as I mentioned, there are a lot of principles, there are a lot of medications. So you have to discuss with the patient what their needs. Any person can continue the medication, but when you come across a patient with the Parkinson's, please refer them as early as possible. Why I am saying so? If you start treatment, their quality of life, if they come to the early stage of the disease, their quality of life can be surprisingly can become to normal as a normal person, especially within the first 5 years. The important thing is you have to give the correct doses. I've seen a lot of prescriptions, quarter tablet given twice daily for years and years. No point. You have to give adequate doses where the patient's symptoms are improving. So sometimes that decision has to be taken by a neurologist. In other countries, actually, if the neurologist doesn't see, they have movement disorder specialist, what we call as, but it's far away from us. The most important thing is to refer as soon as possible. Then you can follow up, and probably then periodically, maybe every 6 months, every 1 year, depending on the patient's condition.
Thank you very much, sir. One more query from the participant. Once dyskinesia appeared as a side effect, can it be reversed?
Yes, it can be reversed, it can be controlled, right? I would say it controlled. For an example, as I mentioned, if the dyskinesia is to levodopa, right? Levodopa is due to the levodopa preparation. As I mentioned, if the levodopa, the dyskinesia is a peak dose, you might have to reduce the doses, then you can disappear. If the patient's dyskinesia is end of dose, you have to increase. Sometimes it comes in a late stage, what we call as biphasic, or very difficult, unpredictable loss, very difficult control with the alteration of the levodopa doses. At that time, there are a lot of medication, not actually 2 or 3 medications, which completely targeting at alleviating or managing dyskinesia. One of the medication is clonazepam. Clonazepam is very useful in reducing the dyskinesia, but at the expense of drowsiness. Amantadine, which has been used as an antiviral, is a very good anti-dyskinetic medication. Unfortunately, it's not available in our system. It's very expensive. A tablet is around 150 rupees. So some patients who can afford can go ahead. Not reversed, I would say. It can be controlled.
Thank you, sir. I think the final question is there a place for MRI, and what are the changes we will see?
Yes, there is a place, but what I mentioned is, if you are quite comfortable, if you are quite confident of Parkinson's, you don't need to have any form of imaging to diagnose. But we would say the patient comes with a tremor, and the patient doesn't fit completely into the diagnostic criteria I mentioned. Sometimes it is important, right, which you have to rule out. But if someone asks for diagnosis of idiopathic Parkinson's, no, right? But when it comes to atypical Parkinsonism, like corticobasal degeneration, PSP, progressive supranuclear palsy, definitely there is a place, because PSP has certain changes which are very much specific for an example, what we call as midbrain atrophy, right? The midbrain atrophy can have certain clinical features due to the bird's beak appearance, right? So there are in a MSA patient, multiple system atrophy, they are called hot cross bond sign. A lot of things are there, but that is for atypical Parkinson's. But if I give a very short answer for diagnosis of Parkinsonism, no. But when it comes to etiology, yes. So that is the simple answer. For idiopathic Parkinson's disease, MRI is not helpful.
Thank you very much, sir. That's all the queries now. Thank you very much, sir, again, for your excellent presentation. It was really informative and really interesting presentation. And I would like to thank on behalf of GMOA and Society for Health Research and Innovation. Also, we would like to present a small token of appreciation to you, sir. Thank you so much, sir.
Thank you, Sinta. It was a pleasure. Right.
Thank you, sir. And for the participants, please follow the link in the chat box to receive your participation certificate. And that's the end of the webinar today. Thank you all for your participation. And I'm Dr. Sinta signing off here. Thank you.